I'll jump right in. We're going to talk about an update on transcatheter pulmonary valve replacement. I have no disclosures. So pulmonary regurgitation, 23% of patients born with congenital heart disease have abnormalities of the right ventricular outflow tract, which is usually stenosis, which is relieved either with a surgical patch or a conduit between the right ventricle and the pulmonary arteries. So for example, tetralogy Fallot, which is the biggest group, truncus arteriosus, transposition of the great arteries with a ventricular septal defect. So just looking at this image here, this is tetralogy of Fallot, as you know, a ventricular septal defect, valvar and subvalvar pulmonary stenosis. So the VSD is closed and a patch is placed to relieve the outflow obstruction. If this happens, you have a wide open outflow tract, and that's great in an infant. As you get older, it becomes a problem. We'll talk about that in a minute. If the outflow is completely occluded or there's no pulmonary outflow, then one needs to place surgically a conduit between the right ventricle and the pulmonary artery. So what are the long-term sequelae of patches versus conduit repairs? So if you have the patch repair, like I first explained, you actually have a volume load to the ventricle because although you don't have outflow obstruction, you get a lot of regurgitation. That regurgitation over time leads to right ventricular dilatation, systolic and diastolic dysfunction, and arrhythmias. If a conduit is placed, typically what happens is that you get stenosis over time. And often, again, if it's placed in the neonatal period, this needs to be followed up with surgery later on, and a larger conduit is placed. But at a certain point, you've done multiple surgeries on these patients, and they still develop conduit stenosis. The effects of stenosis over time is that of RV hypertrophy, diastolic dysfunction from the RV hypertrophy, and as well arrhythmias. If one wants to treat this transcatheter, you certainly can. You can put a stent in and relieve the obstruction, but then that leads to regurgitation, and we're back with that problem as well. So one can replace these conduits or valves surgically. So they can be treated surgically for conduit or pulmonary valve replacement, but there's risks and difficulties of repeated surgeries. So there was a 2003 paper that was published from a series from Boston Children's with 254 valve replacements, describing their experience with patients aged 10 to 21 years of age. There was a 0.7% early mortality, a 2% incidence of early perioperative strokes, an early reoperation rate, mostly for bleeding, of 3%, and an overall serious adverse event rate of 7.9%. This was a retrospective paper. So again, this is not without risk, and again, in patients that need repeated surgeries, this is an issue. In addition, the pain and recovery from surgery is not insubstantial. So because of this, there was an interest in transcatheter pulmonary valve replacement. And in 2000, Philip Bonhoeffer in Paris, France, reported the first man-in-man replacement of a pulmonary valve in a regurgitant conduit using a catheter-based system. And that original design had undergone a few revisions, and work was purchased by Medtronic. And the valve is now called the Melodie valve, and the delivery system is called the Ensemble Delivery System. And this received HDE approval by the Food and Drug Administration for conduits in December of 2010, and was the first FDA-approved transcatheter valve that preceded even TAVR valves. This valve then received full FDA approval and subsequently an indication for valve-in-valve therapy in March of 2017. The Melodie valve is a bovine internal jugular vein valve. It's mounted on a platinum iridium stent, and then it's crimped onto a balloon-in-balloon catheter that has this ensemble delivery system. It's very nice. It has a sheath that covers it and a carrot that allows a single-pass delivery. And the balloons come in three sizes, 18, 20, and 22 millimeters. In addition to the Melodie valve, the Edwards Sapien XT valve that you're all familiar with received FDA approval for pulmonary conduits in March of 2016. And as you know, it comes in four sizes, 20, 23, 26, and 29 millimeters. You're all familiar with what that valve looks like. And the delivery system, again, I would just point out that this valve is not covered when you're putting it in. And so there have been reports of tricuspid valve injury with this, and it is a much more difficult valve to place in the pulmonary position. It's just harder to get up and follow the curves through the heart. The flex system doesn't really help you. It tends to point you in the wrong direction no matter what. I'll also point out that the S3 valve is being used off-label. It's actually hard to get your hands on an XT valve if you really want now. We have a trial of a follow-up trial that we are putting in the XT valves, but the S3 valves are obviously much easier to put in. They're smaller sized, and they work nicely. And we're hoping that we get expanded FDA approval for that valve soon. Just to compare transcatheter pulmonary valves versus TAVR valves. So for the indication for aortic indication is stenosis for pulmonary regurgitation and stenosis. For aortic, it's degenerative disease. In the pulmonary position, it's congenital. For aortic, the etiology is degenerative. In pulmonary, as I pointed out, the etiology is iatrogenic. Older adults for aortic valves and children to adults for pulmonary valves. The annulus for TAVR is non-compliant, whereas for the pulmonary valve, it tends to be quite compliant. We don't pre-stent in the aortic position, and we always do in the pulmonary position, not for valve and valve. The access, of course, for the aortic is artery, and for the vein is pulmonary, which means that we don't worry about the size so much of the sheath. 22 French sheath for the Melodie valve, what they call 18 for the Sapien, but not really, doesn't matter so much. I'd already pointed out the difference in the delivery system. It's certainly easier to put in the Medtronic Melodie valve than it is the Sapien valve, but we have larger sizes of that as well. So again, we're tending to put the Sapien in larger patients that are older and the Melodie valve in younger patients. There seems to be good durability of both valves, and there is a late incidence of subacute bacterial endocarditis that seems to be a little higher in the Melodie valve than in the Sapien valve. We'll talk about that a little bit. So when we looked at our own experience for the underlying disease that needed transcatheter pulmonary valve replacement, the vast majority of our patients that needed it were actually ROS patients. So it's a little bit different. It's congenital aortic stenosis, but then you get the homograph between the pulmonary and in the pulmonary position that becomes stenotic typically, and then also regurgitant that needs replacement. And that was the largest group in our experience, probably because of Dr. Stelzer's large population of ROS patients at Mount Sinai. Then tetralogy, transposition with VSD, and a host of others. The age of pulmonary valve replacement, you can see, tends to be 10 to 19 years of age, tends to be our largest bump, but out to 60 years of age, we've done patients as well. In terms of looking at acute outcomes, there's a paper that I had actually just reviewed and written a review on that's going to be published in JACC, multi-center 17-site registry of 530 patients. 88% patients were Melodie, 12% were Sapien, a serious adverse event rate of 9%. As you can see, there's a good reduction in RVOT gradient and a large decrease in the incidence of pulmonary regurgitation. In terms of medium-term outcomes, patients generally did well. A couple of things, 13% reintervention rate at 1 year, but only 6% were unplanned for the pulmonary valve, which is actually pretty comparable to surgical population. Other reinterventions, like if they needed an ICD or these sorts of things, got included in the reintervention rate, but it doesn't really count so much from that standpoint. There is a 5% incidence of bacterial endocarditis over the 3 years that these patients were followed. It's not insignificant. Certainly it tends to happen in smaller patients where you have incomplete relief of the gradient. So these things are important. It tends to be less of a problem in older patients where we're putting in larger valves and have complete relief of obstruction. Let's spend a couple minutes talking about the future. So we have basically focused right now on these 23% of patients that have conduits between the right ventricle and pulmonary artery, or those that already have large enough placed surgical pulmonary valves. Those we can deal with right now. But the large majority of patients, 77%, where they had the patch augmentation of the right ventricular outflow tract, we can't really deal with the current technology because it's too large and too compliant. The challenges of the native right ventricular outflow tract, it's highly variable anatomy. It tends to be quite large and very compliant anatomy. And these are some, excuse me, CT reconstructions that shows you just the large variability in how that looks. And so one is going to need to fix that. One is going to need to have a system that can accommodate to various anatomies. And so in clinical studies right now, there are two separate systems. One is the Medtronic Harmony system. So these are both self-expanding systems, nitinol self-expanding systems. The Harmony valve is coming in two sizes, 22 and 25 millimeters. And basically, it's a self-expanding cage that has a frame on it, fabric on it, and then the Medtronic Harmony valve has a valve that's already mounted inside, self-expanding. So one puts it in position, expands this, which downsizes the outflow and places a valve at the same time. And the Edwards Altera valve is as well in trials. I said valve, it's not, it's the Altera system. So basically what this is a size reducer that inside you then put a 29 millimeter Edwards Sapien valve. So that's the idea with this. And both of these are in clinical trials currently in the United States. There's a few other systems that are in trials in the Far East. And we'll see, one of the concerns about those that we have seen is that there seems to be an even higher incidence of endocarditis there. So we're going to need to be careful. What you don't want to do is do a high-risk transcatheter intervention to avoid a lower-risk surgical intervention. So again, I think that we have to keep in mind, especially in our group of patients, that, again, we're aiming for long-term success here, and we don't want to do something that's going to be higher risk early on compared to something that we could do later on. If one needs to do another surgery to downsize to put a transcatheter pulmonary valve in, and then later on when that valve degenerates, we can go ahead and put a transcatheter valve, so be it. I'm going to end off there, and I think I've just caught it in under time, so I thank you for your attention.